Hello and welcome to the Surgical Assistant Podcast, a podcast created by surgical assistants for surgical assistants, where professionalism meets passion. Join us in fostering a strong, supportive community where unity among surgical assistants is celebrated and encouraged. Join us and take your career to the next level. Welcome everybody to our latest episode of the Surgical Assistant Podcast. I'm John.
I'm Kelly. Hello.
Hey Kelly, how are you?
I'm good. How have you been?
I'm good. I think we were going to start off this episode with some housekeeping announcements. One would be the 2025 Joint NSAA-ASA Conference in Grapevine, Texas. That'll be Friday, April 25th and Saturday, April 26th. The 25th is going to be the registration and the pre-conference hands-on workshops, followed in the evening by the keynote address, and then a reception with the exhibitors and everybody that's attending the conference. And then Saturday will be the actual conference with it starts out with the breakfast, and then there's a joint welcome, and then the scientific presentations start at 8 and run until the end of the day. And it's great.
Yep. Are you planning on going, John?
Oh, yes. I always try and go. I love the conferences. I really do.
Yeah.
I travel, as many of you know, I've mentioned in the podcast before that I travel right now for a living. And everywhere I go, I talk to the surgical assistants and I ask them, hey, are you a member of the ASA? And do you go to the conferences? And a small percentage say yes, they're a member, and an even smaller percentage say no, that they go to the conferences. They really don't go. And it's a shame because I think
it's unfortunate. Yeah, I agree. I agree with you. And I do want to mention that John and I are both active members of ASA. You are also an active member of NSAA also, correct?
Correct. But when you say active member, it means I go to the conferences. I'm not involved in the board or the decision making at all.
No,
I do voice my,
And I do support with my membership. That's what I mean by active member. I'm supporting with my membership. Yep. And I have been to conferences in the past. I have unfortunately not been able to go to a conference, attend a conference in a while now. It's been a couple of years since I've been to one of our conferences, and just because of one circumstance or another. But I am definitely, as I've talked to you, I'm putting this one in. I am making plans to attend in April, and I look forward to it. And we just wanted to, open up this episode and remind anyone who's listening, if you haven't been involved, first of all, we want to encourage you to be involved. I mean, be involved and get involved in your professional, affiliated organizations. That's what I'm trying to. What's the word I'm trying to say?
Yes. If you want to be recognized as a professional, then you need to join your professional representation. These representative groups, ASAA or NSAA, whatever certification you have. But a lot of people think it's just a way to get CEUs, and they don't want to pay that much money for CEUs. But I think if you haven't gone to a conference, you're truly missing out, because it's the intangibles that you can't account for until you're there. The meeting of other people, meeting people, surgical assistants from other states, and how they function, how they practice, hearing the legislative updates and what's going on, what's new. Those things you can't really put a price to, honestly.
Right.
And I'm sorry, my feeling is it costs money to be a professional. If we want to be recognized as professionals, which we are, some people call us mid-levels, you've got to spend the money. I go to conferences besides the NSAA and the ASAA. We can talk about that on another podcast.
We are
resources out there.
Mm-hmm. We're going to delve more into that. You're exactly right. We have enough to talk about with that to dedicate a whole episode to it, and we are going to do that. But I agree with you 100%, John. It's so enriching to go and to fellowship and network and get to know, our colleagues, our professional colleagues.
Exactly.
And that's what it is for. And these surgeons that have come and give of their time, and other speakers that come and give of their time and really invest in us, I appreciate it a lot. And I do place a lot of value on it. And I couldn't tell that with my attendance the last couple of years. But again,
life happens.
Life happens, right? But I'm looking forward to April, and we did want to open up this episode and encourage, and you and I have talked a very tiny amount, and this is definitely in the planning stages, because this is a brand new, this podcast is a brand new venture for us, but we would love to be able to have a live broadcast from the conference if we are able to, if we can figure that out. So our listeners can stand by for that. And of course, we'll announce in the future if that becomes more concrete. But we did want to put that out there. And that is the last weekend in April, the last full weekend. It's the weekend after Easter. So hopefully in Dallas, Texas, pretty easy location to get to. It's a major airport. So hopefully it'll be well attended, and we'll definitely plan to be there. So
yeah, it's worth it. If you can make it because you'll form friendships that you'll have for a lifetime. I mean, I love seeing my friends at the conference that I haven't seen since the last conference, and it's wonderful. It's definitely something you should avail yourself of. So
yes, yeah.
We're going to start out this podcast, which is probably going to be sort of a controversial topic.
Hot topic coming up.
A hot topic, I think, because people line up on either side of this topic, and we'll let you be the judge of that. But Kelly, do you want to kick it off and tell
and I will
about?
say that yes, I have close friends and colleagues that are hot about this on one side or the other. Mostly one side. I could attribute it to being a Gemini, but I'm very see both sides of an argument person.
Oh, okay.
I can see one side or the other. Oh, I wanted to mention real quick, we are wearing our Halloween hats tonight because it is the spooky season still. So we are right there in that time of the year when we're recording this. This is spooky season. So we're wearing our seasonal hat, our festive hats tonight for the podcast. But yes, this podcast, it is a hot topic, and we want to be open and have a very good discussion about it. If I have to play the devil's advocate, I will and can do that. But we see a lot of activity, and I told John I've seen a lot of activity on the Facebook, a couple of Facebook groups about this topic. So the name of this, if you've seen the title of this episode, is To Scrub or Not to Scrub, Leaving the Mayo Behind.
That is the question.
We're talking, that's the question. We're talking about the blurred lines that sometimes we encounter with our role as a first assistant, especially if we come from a background of being a CST or being in that scrub role, particularly. We do acknowledge that there are some first assistants that do not have that background, and we don't, we're not excluding anyone from this discussion at all. But this talk is going to be more relatable to people that have come from a CST background. So one of the first things we want to talk about, and I'll start off, John, and you can have the next segment here. We're going to talk about the primary responsibilities of the CST, of the scrub person. And we all know that these include gathering supplies and instruments for the case, setting up that mayo and that back table, maintaining sterility of the field. This is a big one to me, maintaining the sterility of that field, because that sounds like ho-hum, but it's super important especially if you're in a facility, a teaching facility, or if you have in and out. We all have to watch anesthesia coming in and out of the room. I mean, they don't care about the sterile field, but maintaining that the sterility of the field is a huge chore. And it's so important. Setting up and organizing the operative area. And by that, I mean, after we get the patient draped, I love those scrub techs, those CSTs that come in and they're organizing those cords and the devices that we're using. A lot of times I'll get my hands in there and help them. But, they're positioning everything on the drapes, putting things in the pockets, everything, where it's going to be easy to get to and clean and neat and organized. Of course, they pass the instruments during the case, anticipating the needs of the surgeon and the assistant, managing any specimens removed and prepping those specimens or cultures for passing off to the circulator, communicating as well, verbally communicating those things, and then prepping and transporting instruments to decontam for re-sterilization. Now, I understand that's a very bullet point list. I tried to hit the main primary. We do understand there's a lot of other ancillary duties that the scrub tech or CST will have. But I think I hit most of them. John, do you agree? Can you think of anything that I might have missed?
No, I don't. I think you hit all the major points. And that's, I want to start out by saying that is a common misconception, because as a traveler in the different places I go to, everybody assumes that if you're a surgical first assistant, you are a surgical tech first, and that's not the case.
Right.
There are two schools where that doesn't require you to be in healthcare at all. It just requires that you have a bachelor's degree, and they are excellent programs. One's at the Mayo in Rochester, Minnesota, and the other's at Eastern Virginia Medical School. I mean, there are two excellent master's level
Good
programs
point. Mm-hmm.
that let me just say the graduates I've met have been top notch. They're very well educated.
Absolutely.
They
Yeah.
know they know how to assist, but they don't know how to scrub because that's not the world they come from. Now,
Right.
a lot of them do pick it up a little bit by, being a part of it, but they don't start out that way. So I think it's good to delineate the two roles. Because if you bring up this topic, you will polarize people immediately. I've noticed
Mm-hmm.
that. I brought it up, and I think it's incredibly important. I mean, the surgical tech role is beyond invaluable. I mean, when you think about what they have to do, I think they
So much.
personally.
Yeah.
I mean, even before I was a surgical tech, I thought they were highly underpaid because of what they have to know. Every procedure, every instrument, every piece of equipment that goes with every instrument. If you just consider orthopedics alone, that's huge. And if you do every specialty, you have to know every doctor's preference. And a lot of them know everybody's glove size and what suture they prefer.
Mm-hmm.
It's just a tremendous amount to keep in your mind. You have to anticipate too. You have to be thinking 2-3 moves ahead.
Yep.
When I was in tech school, my teacher used to say, I could teach a monkey to pass instruments. If somebody says hemostat, you can put it in somebody's hand. That's not a problem. But it's anticipating what the surgeon's going to need as the surgery progresses. So,
Yeah, and I want to I'm going to clarify there because somebody's going to take what you just said and use it. That's not I don't feel like that's a negative, that's not a derogatory comment about the role because obviously we're talking about what a vital role the CST
oh,
plays,
exactly.
but I feel like
Right.
that is a testament to how much more that you do.
Oh,
That you
exactly. And
don't
she
just
didn't mean
I
it as
actually
an,
yeah.
yeah.
I
She didn't
actually
say it
had a
as an insult. She's
manager
saying,
well, I actually had a manager at a facility that I
mhm,
was traveling, in one time. She asked me and I don't wanna jump ahead too much, but she asked me to scrub a case, and I
mhm,
told her, I said, I'm not able to do it. I haven't scrubbed in years, and I don't feel
mhm,
comfortable doing it." And
right.
she laughed and she said, "Well, all it is passing instruments." And she was very
Mm, right.
condescending in that remark, and I laughed and I
Right.
said, "Oh, really?" I said, "Is that all you think?
Mhm,
Is that all you think of your CSTs? That's all you think they do?" So, I just wanted to clarify
yeah.
that, and you didn't say I know you were just
Right.
repeating what someone said, but I wanted to
No, well, the reason she
clarify that
brought
the
it up,
meaning behind that
right.
exactly.
Right. The reason she brought it up was to focus us and tell us that no, this job is much more than passing instruments. If that's what you think this job is, you're in the wrong place because
Yeah,
you have to be
yeah,
thinking 2-3 moves ahead of what
mhm,
the surgeon's going to need. That means you have to know the steps of the procedure and what's needed in every step. And you need to be thinking ahead of that because if you don't have it, because surgeries can take a right turn and you start
mhm,
doing an X-lap and now you have to do, let's say a Bill Roth 1 gastric resection. You got a whole set of instruments you need and other stuff. So you need to be
good
thinking
point, yep,
ahead. So that's the reason I brought that up.
yeah,
It's a very vital role, and we can't do surgery without surgical techs. Now,
that's
granted,
right,
initially it was operating room nurses, but um,
mhm,
techs are just commonplace. They pay techs less. They're a very specific job role, very specified. So that's why they're highly trained and they do this one thing and they do it perfectly. They are
mhm,
excellent at what they do. Like you said, they have to set up and maintain the sterile field, watch for
yep,
breaks in sterile technique, which is so important because especially during a total joint, if somebody gets an infected joint, that could mean the loss of their limb or the loss of their
mhm,
life. So,
mhm,
but it's important. We need to delineate the two roles because I was a surgical tech for 30 years. I loved being a surgical tech. I was proud of it, but I felt
did you
stymied. I wanted to go further. I wanted more responsibility. I wanted more education, so that's what I did. I went and got more education
mhm.
and I don't work as a surgical tech anymore. Okay. But that's my choice. You know, I love being a surgical assistant. I love everything involved in it, but our
Mhm.
focus is completely different now. We
Right.
don't
So
longer, yes, we have to worry a little bit about gathering supplies for the surgery and getting positioning aids and things like that. Yes, of course, that's a team effort. There's a lot of things that are team focused in the operating room, but then there are specific job roles when it comes to my role that is specifically assisting the surgeon with the operation, providing
mhm.
exposure, aiding in hemostasis, whether that's, bovying or tying or putting a stitch in. I can independently do that at the surgeon's direction. Or if the surgeon's not at the field and I think it needs to be done, I can do it then. Um, but people get very angry because I choose not to scrub anymore because to me, I don't want any blurring of the lines. They are very specific job roles. And yes, I was a surgical tech. I don't do that anymore, But people say, what's the matter? You don't think that's beneath you now to be, to scrub a case because now you're an assistant? No, the jobs are completely different. I'm focused on the patient's history and physical, their current condition. I look at the x-rays, I look at the CT scans, I read their H&P before, because I need to anticipate what we're going to need in surgery, what our technique is going to be, how the surgery is going to go, how I can best assist the surgeon with providing exposure or having equipment that he needs to do that, not in the surgical tech role. But people do get very upset about it, and people say, well, I'll help out wherever I can and do whatever I can. If that's your choice, do it. But realize you're blurring the lines. You're putting yourself in an awkward position. I'm sorry, but I've never met a nurse anesthetist that was an operating room nurse that decided to circulate for the day because, oh, we're short circulators. Do you mind not giving anesthesia today and just circulating a case?
Right.
I don't know anyone that would do it because the focus is completely different. And, I haven't scrubbed in 10 years, nor have I mixed cement in probably 15 years. So I would not be any good at it. I mean, yes, I can count from 1 to 10 or 1 to 20, and I can do the surgical count. Sometimes I have to if the surgical tech breaks out early. That's fine. I do that, but I'm not in that role. So I don't want to blur the lines.
Right.
Does that make any sense?
Yeah. Yeah. I mean, and we talked earlier about, as we were, talking about this subject, we were talking about how, when you are moving from being a CST or the scrub and you're in first assist school and you learn how to shift your thinking. So we have to shift our thinking to where we are thinking more like the surgeon. Yes, we do. Like you said, of course, I help set up the room and I make sure we have equipment and I check the functionality of the equipment in the room. A scrub tech can do that too. A CST can do that also. I mean, so those are things that I'm not doing anything that they can't do, but we, as part of a team in the room, we're going to, we want the surgery to be a success. We want it to move along in a timely manner. And in that respect, of course, we're going to do other things to be helpful to the team. So I'm going to check that room. I'm going to make sure that, but how do I know what positioning aids we have? Because I've already thought about, we've already considered the surgery that we're doing. We have looked at the patient. We've looked at our patient. We've looked at any medical issues they have. We know what medications they're taking. We know what the indication for the surgery is. We know their body habitus. How is that going to affect the positioning? To know what position the patient is going to be in, we have to know the surgical approach. What is the best surgical approach? If there's more than one possible surgical approach, then that's when we go to that surgeon and we confer with the surgeon. So we're thinking of all of these things as from the aspect of the surgeon. And I was just having this conversation with someone the other day about people forget that we are taking the place, surgical assistants, and we've talked about this in another episode. We're taking the place of a second surgeon. Ideally, you do have two surgeons. You do have two surgeons doing, especially, bigger cases and bigger operations. But when there's not that second surgeon available, that's when you have your non-physician surgical assistants come in and assist with those cases. So yes, our mindset has to shift. So we're coming at it from not a completely, I wouldn't say a different angle, but a new and more expanded angle than we were as CSTs. And we're thinking about broader things. But yeah, people just get all fired up. And I have made it a practice. I mean, it's common sense that for me, that if I wanted to be good at first assisting, if I wanted to be a good and excellent and above average first assistant, I was going to have to only first assist. I'm not smart enough to convolute the two roles and work in one role and work in this role sometimes and be really, really good at one or the other. I mean, some people can, I guess. Some people can do that. But I listened to veterans in this profession and instructors of mine at school and people that were, I felt like, more wise than me. I listened to them and they said, focus on first assisting. if you need to leave your facility because they're not going to view you any other way. And I did. I had to leave somewhere I worked for, 16 years.
Yeah.
And I had to step out and branch out
Mhm.
to only focus on first assisting to get good at it. And it was difficult and it was challenging and
Mhm.
I plowed through and did it. But why do you think some people, why do you think some people go to FA school and then just fall right back into scrubbing? I know people that have done that. And listen, no, we want everyone to understand we are
Mhm.
not putting anyone down. I am not negating
No.
that.
Nope.
If you are awesome at scrubbing, listen, I love you. I love you in my case. I love my awesome scrub techs that are in my case with me, especially
Oh,
if
yeah.
it comes to something I don't
Mhm.
feel like I'm great at, or hello, orthospine. I love those strong CSTs. So I'm not being derogatory to anybody, but I'm asking you, John, why do you think people do that? Like go to the trouble of putting themselves through FA school
Mhm.
and paying for it and doing that and taking the test and passing it even, but then just fall right back into going into that scrub role and not really progressing in that first assisting.
Yeah, that's a good question, Kelly, and I don't know that I have an answer for it because it depends on what everybody's motivation is deep inside. Like for me,
Mhm.
I was frustrated as a CST because I could not clamp, cut, or suture. By law, CSTs are not allowed to alter tissue in any way. We
Right.
can put a hemostat on a bleeder and the surgeon can put a hemostat on a bleeder and we can take the electric cautery and touch it to it. But we can't do that independently. You can't pick up the bovie and see a bleeder and then stab it, and
Mhm.
stop it. Technically, according to the rule, we can't clamp, cut, or suture. I'm not saying it's not done elsewhere, but that's everybody's individual motivation. Like I said, for me, I was completely stymied. I wanted more. I wanted more knowledge. I wanted more involvement in patient care. I wanted to be treated, or I wanted to be viewed as a peer, or
Mhm.
as a necessary role in that surgery. And I'm not saying that surgical techs aren't that. Of course they are. I mean, we cannot do surgery without them. And a good surgical tech can make the surgery faster, better, and safer. A bad surgical tech can make the case a nightmare. But and I think when we're talking about good surgical techs here in this podcast, but I think you know when I was a surgical tech, I tried always to get better as a surgical tech and be a better surgical tech, no matter what
Mhm.
that took. Whether that was going
Right.
to educational conferences, going to the AST meeting every year, going to whatever in services the local Ethicon rep or whatever put on, I would go to those because it would help me understand. I never wanted to have a piece of equipment that I didn't know how it functioned right. So some people, I don't know. I can't speak to anybody else. I can only speak to my own motivation, but maybe
Right.
other people's motivations are they just want that bump in pay and they don't want that
Mhm.
responsibility.
Yeah.
Because I've met surgical first assistants, and I'm not casting anybody under the bus, but I've met surgical first assistants that I would just consider as a surgical tech that can close skin. They don't
Mhm.
know anything beyond that. They don't want to know anything beyond that.
Mhm.
You know, um,
And that's why, and that's been another, discussion in some social media um, posts and
oh yeah,
conversations. That's been, that we get frustrated as a whole in our profession. We get frustrated when we're viewed as that. But are
oh
we viewed
exactly.
as that? Are we viewed as we're just a scrub tech that knows how to close skin? Because
Hmm.
that's what maybe a lot of people, they just stop. They learn how to do that and then they stop growing, they stop learning more, and they don't really expand their practice or their knowledge. So,
Yes, yes,
we,
and
John and I both have the same mentality that we want to excel. I tell people,
hmm
in first assisting, I want to be working up here at this level.
hmm
I want to know as much as I can of what the surgeon knows. So I'm always going to be striving then, right? Because I haven't been to medical school. I
hmm
haven't gone to all the schooling. I haven't, there's
right,
tons of cases I haven't done. There's tons of things
right,
I haven't seen, but I'm always striving. And so you can come to that different ways by,
hmm
reading, going to conferences, just getting online and doing your research. So, I feel
That's right.
like we can control how people view us, right? Because of that,
Sure.
we have some control over how people view us by how we present ourselves and carry ourselves into surgeries and into our jobs every day.
Exactly. And I think what you said I think hits to the point of what I was saying is that it's your personal motivation.
Mhm.
And my personal motivation is to be the best surgical assistant I can be. And I strive to learn more. I always want to learn. I want to pick up new tricks and techniques. That's why I love working as a locums right now, because I get to pick up these little tips and tricks elsewhere. But at the same time, I'm also hamstringed by the people I follow, because
Mhm.
maybe, and I'm not casting aspersions on anybody. I'm just telling you the facts. This is my personal experience. Okay. It's my
Yes.
personal experience. I've been to places where they have a poor view of surgical assistants because of some of the traveler surgical assistants that they've had before them that have not been very good, that are not motivated, that don't pay attention, that don't seek to grow or just to work in the
Mhm.
role of a surgical first assistant. They are what I call techs who close. Now, this is highly split, unfortunately, and I don't think it's correct, but a lot of people will break surgical assistants into two groups, depending on where you went to school. If you went to this program or if you went to that program. And I can understand why they do it, but that's not the case. It gets down to the individual person and
Mhm.
your motivation. Because let me tell you, I've met some of the best surgeons I've ever seen that went to medical school in Mexico or Grenada and then did a trauma fellowship in the United States. Pediatrics, excellent. One of the best surgeons I ever met was a pediatric trauma and general surgeon that trained in Grenada during the war. He was actually evacuated by the Marines, but
Wow.
a guy is phenomenal. One of the best surgeons I've. He's fast. He's good. He's just knowledgeable, excellent. And some of the worst surgeons I've ever worked with have gone to Harvard, Yale.
Mhm.
Doesn't matter. There's going to be a
No.
10% factor in any profession, whether it's surgeons, Navy SEALs, police, fire. There's always what I call that 10% shitbag factor. Pardon my expression. There's always going to be that no matter what the profession is. So
That's
it's the
true,
same with
and that's
surgical
true.
assistants.
Mhm.
At the hospital was working at as a surgical tech at the time I went through my program, I asked a very experienced cardiac first assistant who I respected and looked up to. I asked him if he would teach me, if I could scrub in with him and learn, just to learn the basics. I didn't want to learn to do cardiac at the time because I was just a student, but I asked him and he said, "No, I won't train somebody from your school because that's a correspondence school for surgical assisting." And I was like, that really hurt. And I told him, I said, "Sir," I used his name, but I won't use it here. I said, "Sir, I think it depends on the individual." And by the end of by the time I was ready to graduate, he actually recommended me for a job. And he actually told me that, he made a
Nice.
mistake and, it depends on the actual person and not the
Mhm.
program that you can have an excellent student. And besides, I'm not saying all programs are good, but programs, just like surgical technology programs, they just teach you the basics. All of your learning
Mhm.
happens after you graduate.
That's right.
That's why
That's right.
continuing education is so important. Um, but I think it comes down to your personal motivation. I've had, well, I'll just tell you an experience, and you guys can judge for yourself. But I was at a hospital where they put me with a neurosurgeon. The very first day I worked with him, he offered me a job with him. But while we were working, he was telling me the story of the person that I replaced. Now, this was around Christmas time a few years ago. I saw the job pop up. I asked my recruiter to submit me to that job. She called me back and said, "It's already closed out. Somebody took it." Fine. After Christmas, it pops back up again. I did the interview. I got the job. I get there. I work with this guy, and he tells me this story. He said he has been working with this traveling first assistant. They put her in his room. I won't say her name. He did tell me her name, but I won't say it because that's not the point of this. I'm not calling anybody out, but he was telling me a story. When he closes the lumbodorsal fascia, he likes it closed watertight. He interrupts it and he wants every knot to be tight. He doesn't want any
Mhm.
air knots on that at all. And I get it. So I
Right.
did it. I took my time. I two-handed tie. I pushed them all down and made sure they were tight. The very first time I worked with him, I asked him to inspect all my knots. He said they were fine. So then he proceeded to tell me the story. He said that this one surgical assistant, every time she threw her knots, she always threw an air knot. And that layer is so important. He said, finally, after about the umpteenth time of me telling her she's doing another air knot, she threw another air knot and I pointed out to her. He said, I said to her, "You threw another air knot." And this was her response. And this shocks me to this day. She just looks at him and goes, "Wah, wah." And I was so angry. I was like, what kind of person? That's your response? The surgeon you're working with, who you're supposed to be helping, tells you exactly how you want it done. You're
Well, it
doing
sounds to
it
me like he
wrong.
lots of patience with her too.
You continually do it wrong. And he tells you, and that's your response. You don't know this guy. If I know him for 30 years and I was joking around, maybe, but no, I would never do that because it's the patient that's going to suffer. And this guy, I swear to God, he spoke for me at one of the NSAA conferences when we had it in Cincinnati. Great doctor. I love the guy. He's fantastic. I still keep in touch with him. I text him now. He's in a different city, but he is so nice. And he just looked at her. He said, "Get out of my room." And I mean, that was the extent of him throwing instruments and swearing because he's just a nice guy. He doesn't do that. But, and she was gone the next day and then I took her place. But the mindset, I mean, you're a traveler, number one, but that's, how could you not care to do your job the best that you can?
How could that not bother you that you weren't doing?
Right.
Yeah. And like you said, that's a vital thing is getting those knots down tight, making that water tight. I mean, yeah.
Exactly. I mean, it will never be the best, but you want to shoot for the best because maybe you'll end up second best and but that's your response?
Right.
To mock him? To do that? Well, I just still, it shocks me to this day.
Fires me up too.
If I ever meet her, I will slap her. I'm sorry, because that is just to wake her up. I mean, come on, man.
It's just not acceptable. And you can see, our passion in that is that you are representing, if you have FA behind your name, you're representing this profession that we obviously care a lot about and we hold it in high esteem. I hold it in high esteem because what an honor it is to get to assist a surgeon and be that advocate for the patient as well. We're kind of that bridge. We're in such a unique position, John, to get to work so closely with the surgeons and assist them in these, their work. But then also have the relationship with the patient. And, a lot of people say, well, the patient's asleep. Listen, I try and go introduce myself to my patient. I try to assure them that they've got a great team taking care of them. I want to instill in them confidence that they are going to be well taken care of and well looked after while they're in the most vulnerable position that they can be in. I mean, I take that seriously. I do. And I take my skills seriously, from closing the tiniest little, neck prick up here where we've put in a port or an HD catheter to, closing a big spine or, some of the bigger things that we have to close. I want to do that at such an excellent level, yes, for the patient, but also so that my surgeon will have confidence. It's a really big deal to me that my surgeons that I'm working with they have confidence in me that I'm going to do, and they trust, that I'm going to do a good job in their stead, because we're working under their direct supervision, right? We're working, we're on their watch. If we screw up, it's on them, y'all. And that's
on them,
it's just not to be taken lightly. I don't want to sound preachy, but I'll get serious about it in a minute. I mean, it's a big deal. And I'll be the first one to be frustrated that a surgeon's not trusting me after some time. But also I tell them, hey, dude, I don't blame you. I do not blame you for not, because it's a big deal. So some of the surgeons that I work with on a daily basis, and I know them very well, I will tease them when, I'll tease them about not trusting me to do things. I'm like, we're going to get there. We're going to get there. You're going to trust me. You're going to let go a little bit every time. And they'll laugh and cut up with me. And then I work with some surgeons that really let me, they trust me all the way, and they give me a lot more leeway. And that's just the way this profession is, right? And especially if you're traveling, you're going to meet all kinds of surgeons. But I just wanted to say all that to say that that's why we take it so seriously, because it is a serious thing. And
you bring up a good point, and I just want to interject this for a second, though. I view it, and call me crazy, hokey, or whatever, but I think that this, and I felt this way as a surgical tech too, because I include all operating room staff in this, but this I look at as a sacred profession, to be able to participate in somebody else's healing, because they are completely vulnerable. They put they put themselves in our hands. They're asleep. They can't do or say anything, and it's up to us to make sure that everything is done correctly. And, well, I shouldn't say that, not that, but I view this as a sacred profession. To participate in somebody's healing is I think the most noble profession that there is. And they do surrender everything and trust us completely to do that. That's why I want to be the best professional I can be.
Mm-hmm.
And some people call that hokey. I don't know. That's just the way I've always
No,
looked
I
at it.
think, I mean, like, hey, when I'm the patient, when you're the patient, don't you want somebody in
Mhm.
there taking care of you that feels like that? I do. I mean, and
Exactly.
that's the way I
Exactly.
look at it too. And we do understand, you and I both. Of course, we're not talking about we're the only, we bear all this burden alone. We understand that we're part of a team.
Right.
We're part of
Hmm.
assisting anesthesia and
Right.
intubation, extubation. We're communicating with anesthesia about the welfare and being of the well-being and welfare of that patient. We're corroborating
Hmm.
with our circulator. We're hand in hand with the scrub tech, and we're all, working as a team. Of course, we want
Hmm.
to, reiterate that. But it is, and that's just coming from where John and I have the same heart on that. We just do. We
Hmm.
have the same heart and we have the same opinion on that. We want to be above average. We want to stand out to our surgeons and to our patients and to our team. I love to be a
Right.
help to my team. I love for people to
Hmm.
say, "Oh, good, I've got Kelly in my room today." And that
Hmm.
feels good to me. Maybe some people don't care. I
Sure.
care. I care because I want to be a helper. I want to be,
Hmm.
and I'm not going to have a great day every day. I'm not going to be in a great mood every day, but
Right.
I want to be that person that I am going to buckle down and do my job and carry my
Hmm.
weight and even go above and beyond, hopefully, most of the time. So I feel like, though, going back to what we talked about, what we
Hmm.
were discussing about why some people do go to FA school. And then I feel like sometimes it can just be as simple as doing what's comfortable. Like,
That's
I'm
true
just going
too.
to go back, if they're not in a position where they can maybe change hospitals or change their place of
Hmm.
employment, yeah, they're going to go back to what's comfortable for them.
Right.
And especially if they want to travel. These days,
Hmm.
I know you can attest to this. I haven't
Oh
traveled
yeah.
since 2023, and I'm kind of staying put for right now. But rates aren't what they were.
Shoot, not right
They
now.
they've
That's for
they've
sure.
dropped, and so a lot of times, hey, CST rates are just as good, or even if not better than some FA rates. That's right or
Hmm.
wrong. We can have a whole talk about that, but we're not going to. Um, so a lot of times it's just a practical reason. Like, hey, I'm a CST. I did go to FA school, but
Hmm.
there are more lucrative jobs available. I have more choice in
True.
jobs available as a CST. So I'm just going to go back to doing that. So yeah, you're right. I think it's individual and I think it's different
Hmm.
reasons, but our whole point in talking about it, I feel like, is to just is this part of it is to encourage
Hmm.
you that if you're in that situation and you went to FA school and you're just kind of got, for whatever reason, you got lazy, you got comfortable, you just got complacent. Maybe you just are like, I'm just going to I'm going to take the easy road. I'm just going to keep doing well what I was already
Hmm.
doing well. And if they want me
Hmm.
to close skin every once in a while, I can just pop in and do that. If you want to, it's not too late to elevate yourself and to get more experience. You can do that. And
Right.
we want to encourage you in that. And so you need to ask our opinion or get on one of the Facebook
Hmm.
pages and ask other people's opinions, ask colleagues, how can I do this? What are some ways that I can step out of this role again and really kind of enhance my profession or my role as a first assistant? What are some things I
Hmm.
can do? People will answer you and people will help you in that. So I do want to encourage you and kind of exhort you right now, if that's you
Hmm.
listening. Now, what do you do, John, if these days are you ever asked in your travel roles, are you asked still to scrub?
Oh, I'm glad you brought that up. And
Mhm.
I've learned the hard way to bring it up. I always bring it up in the initial phone interview
Mm.
because it won't be anywhere else. But like I said, a lot of this has been conflated because most every job that I've seen advertised in the travel space is surgical tech first assistant, even though there's no such thing as a surgical tech first assistant. I'm not going to get into it. It had to do with the way they push the two credentials together, but there is not. I don't go by
I
CST. I don't even think my
listen,
CST might be currently active. I'm not sure, but I am a CSFA/CSA. I have both certifications. I only use those two designations. So I get that flat out addressed up front in the phone interview. And I've lost jobs because of it.
right.
There was one just recently that I really wanted to get at Columbus Medical Center. And she asked me, I said, listen, do you require me to scrub cases if there isn't anything for me to do as an FA? if I'm not needed as an FA? And she says, well, yes, you do. And I was like, well, I'm sorry, I don't do that. And she said, well, what do you think I'm going to do if I don't need you for cases? You're just going to sit around and get paid? I said, of course not. I said, I could pick cases. I could help move patients. I can turn rooms around. I can expedite other rooms. I'm not going to be sitting around, but I don't feel comfortable scrubbing. I tell them that. Number one, my malpractice insurance does not cover me to scrub cases. It covers me as a surgical assistant. Number two, I haven't done it in so long, I wouldn't be any good at it. Number three, they're very designated specific roles for a reason. So I get that. And most of the times it's not an issue because they need surgical assistants, Now, I've been to places where I've come as a traveler and their native surgical assistants that work there, their in-house surgical assistants, have volunteered to scrub cases. But that's everybody's personal decision. We're not saying don't scrub cases. That's not what we're saying. We're saying it's your own personal choice. But I find that people get very upset at this particular fact that, well, I want to be the greatest help I can be. That's wonderful.
Right.
And I think you should. But what happens if something goes wrong? And I always look at it this way. It's sending the tech to lunch before the case is done and you working in both roles. We can't work in both roles. We can't be a scrub tech and a first assistant on the same case. And my thing is, what happens if you have to reopen that patient and it's just you and the doctor now? What role are you functioning in? Are you acting as the first assistant or are you acting as the scrub tech? And if you put a stitch in, then did you do it as a first assistant? Okay, if you did it but you're listed as the scrub tech, so then you can't
it's very
be doing it. I don't know. For me, too much gray area, and I don't want to deal with any of that legal wise. I don't want anything. I want to protect my license, my certifications. I love this job. I love what I do. I don't want anything to take it away from me. So and it's not because I hated being a scrub tech. I loved it. I loved it. I really did.
Right.
But I love what I do now.
I don't get why it's the perception that a lot of times it's the perception that we are too good or that's beneath us. That doesn't have anything to do with it. I think you just, you verbalize perfectly.
Fruit.
Right. It is. It is. So
people say that.
One of the outcomes of this conversation that I feel like needs to be a goal of is that if you feel one way or, if you feel strongly that you are done scrubbing, that you haven't scrubbed in a while, that you have in fact, narrowed your practice down to just being first assistant, I feel like it's important. And if you feel strongly that you don't want to be in that role anymore, just stand firm and be upfront, be honest, be transparent with your managers, with your people that you're talking to, and be clear. And if they think badly of you or they accuse you of, well, you think you're better, sometimes we just have to take that and say, okay, well, I'm sorry you feel that way, but this is a professional decision. And I, in the spirit of being fully safe for the patient, it's not a good idea for me to have me in that role. I myself have done that. And when I travel, I'm the same as you. I would tell the managers, I don't scrub. I haven't scrubbed in a long time. There are a lot of whole area of specialty of case types that I didn't scrub even when I was a scrub tech. So I really, I'm not able to do it. I don't have the ability to do it.
Right.
Now, where I am now as staff, and I did come back staff to my current hospital back in January of this year, they know that I don't, and they don't ask me to do it. Now, I say that they don't ask me to do it on regular. Just this week, I was asked to scrub 2 cases. I worked 12-hour shifts. Yeah, I worked 12-hour shifts. They were small. I had to relieve somebody to go home at 5 out of a podiatry case. She was literally closing, and I finished up with her, and I scrubbed in, relieved him, and, put the dressing on. And then I was asked to scrub in a, like a port. Like I scrubbed a port insertion. And they know that I will do it to help them out. If it became like a regular thing and they, then I would have to go have a talk. So it's not that, I'm kind of that school of thought that if you can do it and they need help and you're not in a facility that's taking advantage of that and having you do it on the regular, I feel comfortable. And for me, I feel comfortable doing some of those cases, and I might roll my eyes or they know, or get a look on my face like, I'm like, you really want me to scrub that? And she said, yes. And we have a great charge nurse. But I was like, okay, I'm going to do it. I'll do it. But
And I also think it's different if you're employed
it,
as a surgical assistant at a hospital,
right.
at a facility, or if you're a traveler too. That
Yes,
makes a difference.
yeah, it
People who
does
are
make a
employed
difference.
may feel that they have no obligation but to say yes if they're asked in that situation because they
Right.
do work there. And like at the end of the day, we're not here to tell you whether you should or shouldn't. We're just trying
Mhm.
to present both sides
Mhm.
and say that it's probably not a good idea, but everybody has to make that decision for themselves. If you want to
Right.
be, you know, help and do whatever you can and be, always there to
Yeah, be a good team
do whatever
player.
they
Yeah.
ask,
Mhm.
that's fine. But realize there might be
Yeah.
professional consequences down the line,
Right.
things that we can't foresee right now. And then I
Mhm.
say it too. I've been to facilities where they allow their techs to close skin, depending on their level, within the facility, whether it's a tech 1, a tech 2, or whatever.
Mhm.
And I asked them, I was like, "Are you allowed to do that?" "Well, the hospital has a policy that says we can." And I was like, "Okay, but realize your job description says you can't. And it doesn't matter what the
Mhm.
hospital policy says, because at the end of the day, it's if it ever comes to court, it's gonna where are you taught in surgical tech school how to close skin? Oh, we're not, but I took a 1-hour ethicon class and a surgeon signed me off.
Mm.
And not that it's ever gonna come to that. I doubt somebody is gonna be
Right.
called into a court case for the way the skin was closed, but just the same, it's the same. You're acting outside your scope of practice. So
Right.
my
It's
job
a
role now is as a surgical first assistant. I did
right.
surgical tech for 30 years. I loved it. I don't do that anymore, you know.
Mhm.
But it's funny, I don't really hear this argument coming up in other professions. Like I just said, the example I gave earlier about nurse anesthetist and
Right, and
circulating nurse.
I'm glad you
You never
brought because
see that.
that's a perfect segue into what I was going to say and what's next. Yeah, other examples of role change as a result of furthering education or training. Guys,
Mhm.
here it is. Like, here's just a few examples to name a few. RN to CRNA,
Mhm.
certified nursing assistant to RN.
Right.
And I
Yeah.
did bring this up at one of to my managers recently. I said, "Do y'all ever Do you ever, if you were a nursing assistant before you became an RN, and I know a couple of them were, I said, it's the same as them asking you to go upstairs and work in that role. Would you be willing to go up and be a nursing assistant? And most of them, when they think of it like that, and I'm talking about when you're having a conversation with someone that
Mhm.
doesn't want to see your point of view
Right.
and staying in your role, okay?
Yeah.
So CNA to RN, RN to advanced practitioner RN,
Mhm.
CST to RN,
Yeah.
CST to FA, LPN to RN. Paramedics a lot of times go to RN, become RNs or
Mhm.
become
Sure.
anesthesia techs and CVOR. A paramedic can do a lot as an anesthesia
Mhm.
tech in a CVOR setting. A lot. I mean, they put in
Mhm.
art lines, they start the IVs, they do a lot, work hand in hand with anesthesia in those
Mhm.
CVOR cases. So those are just to name a few. So
Mhm.
it seems to me that there's not this discussion in those other areas, and I just don't understand why it's such a big like head to head thing
Mhm.
for us. You're well within reason to once you have furthered your education and furthered your training, you're well within
Mhm.
reason to be in one role or the other. So don't let anyone
Right.
bully you or make you feel bad about it. I'm well established in being a first assistant. I'm at my local facility now full time as staff. They know that I
Mhm.
will scrub small cases if they need help, and they're
Mhm.
wonderful to not take advantage of me in that. We do have other first assistants. Generally, all of our first assistants on our team, nobody wants to scrub. Like we haven't,
Right.
like they haven't. I don't say just they don't want to, but they haven't scrubbed in so long that
Mhm.
that's just not so there's a very good, healthy understanding at my facility, and there's a very good delineation, and I appreciate that about my particular facility that I'm at. But
Yeah.
we just want to encourage you to, try not to get in arguments with people about it. Stand your ground. You have a
Mhm.
good argument to be in a delineated role as a first assistant if you've moved forward in your career that way. And
Mhm.
we want to just encourage you. And we know it is a hot topic though, because
Oh,
you'll
yeah. You
you
wanna
just have to
start a
look on
fight on
Facebook a
Facebook.
minute. It's
Yeah. You post that question on Facebook. Somebody posted a survey not too long ago, I think about something like that. And then it immediately became, disparaging the program that the person came from. Like, "Oh,
right.
every assistant I've seen that graduated this program sucks, and everybody I've seen
Right.
from this program is excellent." And I'm like, "Bullshit.
Yeah,
Pardon
we
my
need to
language,
put
but no.
yeah.
It
We
comes down
did.
to personal motivation,
It
and
sure
that's why I
does.
wanted to do this podcast too. That's why Kelly and I wanted to do this, is to foster unity in our profession, because we are fractured.
Absolutely.
We are fractured as opposed to where you went to school. We're fractured, as what
What your
certification you have.
background, yeah, what
Right.
certification, what
But
background, yeah.
everybody's welcome in this podcast, and that's what it's here for. It's here for everybody, whether you're a first assistant, not a first assistant, no matter your certification level, or if you want to go to first assisting school, or if you don't care, you just want to learn what it's about.
Whether you've ever
I
scrubbed or
mean,
not, we want,
right.
yeah.
But we're all in the same boat. We're
Right, and
all
we can
here to
help
get
each
better.
other. Yeah, we can
Right. We
help
can
each
help each
other
other.
and right. So we all have something to
Because
bring to the table for sure.
just in my career, I've seen this profession advance. Like, I
Mhm.
started in Florida. There were no independent. I knew one independent surgical first assistant, one. And Bill's a great guy. He's excellent. He's somebody I've tried to model myself after because he's
Mhm.
excellent. He's well respected. And he's still doing it to this day, and he's still doing a damn good job. But I didn't know anybody. Everybody that worked in the operating room was either an RNFA, in the assisting role was either an RNFA or a PA. But now, I don't know a hospital in Florida that doesn't employ surgical assistants. I see travel jobs open all the time for Florida,
Right.
Tampa, West Palm, Miami, Fort Lauderdale. It doesn't matter. If there's a hospital,
Oh, mhm.
there's a role.
Yep.
So it's come a long way, but we still have a long way to go,
Yeah.
But I look at it's just like the PAs. The PAs had to fight for their ground early on too,
Yes, yeah.
And now we're seeing nurse practitioners, or now they're called, I think they just lump them all in together and call them APP, Advanced Practice
Mhm.
Providers.
Mhm.
But I know I have a friend of mine that does cardiac surgery, and he's considered a mid-level at his facility, and this person is excellent at what he does, very good at what he does.
Yes.
He works independently. He harvests vein and artery independently.
Mhm.
That first assistant I told you about where I worked that said he wouldn't recommend me, I watched this guy open the chest by himself. That was a routine.
Yeah.
The surgeon came in the room, spent time out. He left. This guy opened the chest, prepared the chest, and went down, harvested the vein. And then after he harvested the vein, he closed the leg, came back, and assisted the surgeon with the bypass.
Mhm.
That blew me away the first time I saw that. I was like, oh my God, we can do that?
Yeah.
But
there's a lot, and there's a lot of, there's a lot that we can do. There's a lot that's in our scope. Legally and even facility wise we're under the direction of that surgeon. And so that trust factor is huge, and there's a lot that we can do. So if that's your ambition, hey, it's out there for you to get and grow and know you can, just elevate yourself and carry yourself in a professional manner, and you can be there and to have respect, you need to earn it. You need to be respectful to you need to be, worthy of it. And, and we just want to foster that and put that out there that's our goal as well. Yeah.
Right. This is a controversy that's out there. But at the end of the day, like I said, like Kelly said, we're not here to tell you what to do. That's your own personal decision. Excuse my voice. I've had a sore throat today. I'm not feeling very well, but at the end of the day, it's up to you to make your own decision, but consider everything. Consider the legal ramifications. Talk to other people about it, talk to other first assistants, find out what they do. I do what's best for me in my current role right now. And it's not that I don't want to help. It's not that I have anything against surgical techs, but immediately people want to make it that. Oh, it's beneath you. You were a tech. Now you're too good to scrub a case. No, it's not that at all.
Not at all.
So, we're
so
just trying to
so that's
further
a
the
big,
profession.
Yes. And, another just want to take away nugget is to communicate with your managers, your charge nurses. And if you're traveling or thinking about traveling, that is a conversation that you want to have, and a question that you want to ask ahead of time is what their expectation is regarding your scrubbing. Again, because we all know, and this is another hot topic, is that title, that made up title of CSTFA. There's no such thing. There's no such thing. I'll say it again. There's no such thing as a CSTFA. There's no such thing as that. Okay. You can, like John said, you can be a CSFA or CSA/CST, CST. However, you can have both titles, but a CSTFA does not exist. So because of a lot of hospitals, though, do just put that made up title out there, it's important to have that conversation and clarify that, and clarify what expectations are when you're interviewing, whether it's for a staff job or a travel position. So if you don't take anything else away from this, know that's a good nugget to take away from this episode. This was fun to talk about, John. I know this was a fun episode to talk about,
we'll see what kind of devastations happens in the comments. But
yeah.
I think it's but that's another. But it illustrates the point of if you can leave the facility that you were working as a surgical tech to a new one to become a surgical first assistant, it'll be much better, because trust me, they will always view you as a surgical assistant. Surgical tech, excuse me. Even if you become a PA, they will still see you as a surgical tech. I'm sorry. That's just the way they know you, because especially if you stood out in your field and you were somebody they could always rely on and always count on, which most of us are. They will. I mean, it's just
the nature of things. It's human nature. They're going to pigeonhole you into that, especially if you're really good at it. They're going to pigeonhole you. It's their comfort. They have somebody they can count on in that role. And a lot of times that's just the natural, what happens naturally. So I should have clarified that when I did say that way earlier in the podcast about leaving your facility. That's the reason why. Is because it's hard for them to overcome and let you kind of cut you loose. Not that it never happens. I've known people that have successfully transitioned and been great, but I feel like that's few and far between when that happens. So just, as long as you have
brought
that.
it up. You brought it up. I'm just beating a dead horse. That's all.
Yeah.
Because I think
in case I didn't say the reason, I know I said leaving your facility, but I didn't know if I said the reason why. I'm just not trying to encourage people just to duck out, especially have a good thing going. But hopefully hospitals, are going to come around. Operating room administration is going to come around and see that these roles are definitely two different roles. They are distinct. Yes, we meld together, and a lot of times we're just overlapping, and that's fine in the team environment that we have in the operating room. But hopefully, as we bring more awareness to it and carry ourselves the way that we've talked about carrying ourselves in this episode specifically, that managers and leadership can see that there is a delineation between the roles and a distinction, and we can just continue improving from there. So, yeah.
I think so. That was great.
All right. Well, I think that's going to do it for today, unless you have anything else to add, John.
No, I don't think so. Let's wrap it up there. And
all right.
Leave us a comment. Don't forget to like and subscribe, and we'll go from there. So
spread the word about the podcast too. Yeah. Yep.
Yes, please do.
Yeah.
Please do. So thank you very much for joining us.
All right. Bye, everybody.
Bye.
Thank you for joining us today. We invite you to like, comment, and subscribe to our podcast. Feel free to look us up on Facebook at The Surgical Assistant Podcast. If you like, you can also email us at thesurgicalassistantpodcast@gmail.com. We look forward to seeing you on the next episode. Content of this podcast is created for surgical assistants and is educational only. It is not intended to diagnose, treat, or offer medical advice on surgical conditions. No patient-specific information is shared, and all HIPAA guidelines will be adhered to.